October 18th, 1997, was actually working in a little community hospital just north of Reno, Nevada. So anyway, I was taking care of a patient who was in the advanced stages of AIDS, was dying. I'd been taking care of him for 3 days. And in the process of caring for him, and those of you who are nurses, nursing students, have been around for a while. You remember the times when, way back in the 1980s and 90s, when we ran IV fluids and we didn't put them on pumps? Yep. And so unless it was something heparin or something titratable, we just ran it by gravity. So that was the case then. And so had an IV line that was running that had blood that backed up into the tubing, as frequently happened when we ran them by gravity. And so the line occluded, had blood that was backed up into the tubing. So what did we do in those days? We didn't want to have to reestablish the patient's IV access. I knew he was dying of AIDS, and this was in the 1990s, and there was not a whole lot we knew about HIV and AIDS at that time, other than that it was caused by exposure to blood, and that people died from it. And they died from it in a pretty unpleasant way. So the last thing I wanted to do was have to reestablish his IV access. So I did what we did at that time. I filled a syringe with saline, and so what do? We used to have a rubber port on the IV line tubing, accessed the IV line tubing, attempted to flush the line, didn't flush, it then aspirated the line so you could pull blood back into the syringe. And that's where you pray to the IV patency gods and say, please, 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 please. And started to flush again, and it started to work. In the process of doing that, the patient that I was taking care of became very agitated. He startled, did kind of one of these things, and when he startled and jerked his arms, the needle flipped out of that rubber port and right into my left hand. What I did was the things that they taught us to do at that time. You squeeze all of the blood out of it that you could at the time, wash your hands, report to the emergency department. Was evaluated in the emergency room. All of the baseline testing was done. We already knew that the patient had AIDS. So all of the baseline testing done. And was then evaluated and was assured that really you're going to be fine. Started the medication. They said, just to be sure, we're going to start you on the post-exposure prophylaxis that we had just instituted in the hospital. And we're just going to make sure that everything is fine. And after 3 months, everything was tested, everything was negative. HIV, hepatitis C, hepatitis B, all negative. And what we knew then, and we still know, is that 90% of seroconversions, if you're going to test positive, are going to test positive within 3 months. I went back at 6 months to then be retested. And really, I followed up with a 6-month test. I was so sure that I was fine. Followed up with a 6-month test because the employee health nurse was chasing me around and saying, you need to have that test done. Okay, all right. Okay, it was tested again, and was negative actually at 6 months. So really, it was about 2 months after that. Got really, really sick. I was admitted in the hospital a couple weeks after that, and he said, I don't know what's going on, but you had that exposure. You had that needle stick. It's been 8 months, but maybe just to cover our bases, why don't we do an HIV test? We got the test results back, and that's never a really good way to start. Okay. And it came back 250,512. It's a number I'll not forget. Viral particles per milliliter of blood. So for a point of reference, a test with a value higher than 50 is a positive test. And that was the moment where it really hit that this is a big deal. And my first thoughts really were my kids and my daughters, Rebecca and Caitlin, were 3 and 7 at the time that my needle stick injury happened. They were 4 and 8 when I was diagnosed with HIV. The first doctor that I went to see, the first infectious disease doctor that I went to see after my needle stick injury, said, well, pretty much plan on a disease trajectory of probably in the area of 10 years diagnosis to death. And so you do the math, and I'm a single mom. I've got 2 little girls that are 3 and 7, and they're telling me that I'm going to die probably within 10 years, if not sooner than that. But within a couple of months of starting the treatment, one morning woke up completely yellow. AST, ALT, both over 1,000. Bilirubin right in the area of 7. And what they found was that I also had developed hepatitis C. But I like to really talk about it through the experience of my daughters because, you know, in my house, I'm the only person who was actually infected, who actually has the HIV virus in my body. But every person in my house and every person in my family has been equally affected and in many ways infected by the HIV virus. How much does an HIV diagnosis affect not just the person, because we as nurses and as healthcare workers and people who work and take, you know, this knowingly risk that we may be exposed to the blood and body fluids of other people. Our families, though, don't take that risk with us. And so it's not a matter of how does it affect us, it's a matter of is it acceptable and is it okay for this to ever happen. Needlestick Safety and Prevention Act in 2000, which really made the big difference because then it really was no longer an option to have safety in healthcare or to not have safety in healthcare. So U.S. needlestick legislation required a few things. Engineered sharps injury prevention technology, which basically says anytime you have something sharp that can be made not sharp, or anytime you have something sharp that can be shielded, blunted, encapsulated, or retracted after it's used, it has to be. There was a time that we had about 800,000 needlestick injuries every year in acute care facilities. We've cut that number more than in half. But the reality is we still have 384,000 needlestick injuries every year. What we know is that nurses consistently experience the highest number of needlestick injuries. Why is it that nurses are the most commonly exposed? Say again?
That's who's using the needle.
Yeah, we use more needles. We use a lot more needles. So what is it that allows it to continue happening? Is it, in many cases it's referred to as a communication issue. Is it okay when you're working with somebody and you go and you say to somebody and you're like, you know, Jan, I'm not really comfortable with, you know, I saw you not activate that safety device. I can pick on people. You know, not activate that safety device and put it in the trash. And I'm really worried and concerned about that because then that's going to go, you know, it goes down to housekeeping, it goes to laundry. Thing is, as nurses, if we get stuck, we know who we were exposed to, we can test a patient, and we can make informed choices about treatment. When the people down line in environmental services are then stuck, they don't know who they were exposed to. They don't know if it was the patient with full-blown AIDS who's injecting IV drugs, or if it's the 93-year-old little virginal nun. They have no idea, and so almost always have to be prophylaxed. So the real question is, what is the correct device for the procedure being performed in the setting where it's being used by the people using it? The difference between passive devices and active devices. So a passive device, what is a passive device? So passive device being one that doesn't require any action on the part of the person using it to be used correctly. Meaning that it's just automatically, no matter what you do, once you've finished using it, the needle is either clipped, capped, withdrawn, shielded in some way, and there's nothing that the nurse or the user has to do with it. As opposed to an active device, where the person using it has to, in some way, activate the device. The safety features are only activated somewhere between 17 and 60% of the time, which means that they're not activated 40 to 83% of the time. So activation is so important because we look at somewhere between 21 and 29% of needlestick injuries are just the result purely of non-activation, of not activating an available safety device. So if you break that down to numbers, that is, you know, what we know is this number of 384,000. That's about 100,000 needlestick injuries every year are specifically are from a device that has a safety feature on it that was not activated. So those are injuries, about 100,000 of them, that are entirely and completely 100% preventable. These young people coming into nursing really need the opportunity to work in a safer work culture. And I used to say safer work environment, and we've really dealt with the environment to a large degree, but a safer work culture where safety is not an option, where we don't look at it and say, okay, yeah, we need to be safe, but it's really the mandate. And in my final thoughts, I share from Mahatma Gandhi, and really is to go back and be the change. Be the change that you want to see in your workplace and in your profession. Because all of us who work in direct care roles have the ability to prevent a story like mine from being told, from preventing it from being your story, preventing it from being another young nurse's story.